I figured that the best thing to do is start with the basics of conventional mechanical ventilation, because unless everyone is familiar and understanding the basics of conventional ventilation, you really can't talk about high-frequency oscillation or high-frequency jet ventilation. So what we're going to do is talk today about conventional mechanical ventilation and some of the basic precepts of that with current literature. And I'm not going to go over a lot of the current literature because we just don't have time to do that. But all of this is based in current thinking and current literature from the people that do ventilation. And then we're going to move on Monday to oscillation. We'll build on what we talked about today and talk about oscillation, and then on the following conference we'll talk about high-frequency jet ventilation. I've given you 3 really, really good references that I highly recommend if you are interested that you look up, and almost all of the information that I will give you today is in one or more of these references. Marty Kessler, who is another person very, very interested, did a lot of work in conventional as well as high-frequency ventilation, did a beautiful state-of-the-art review which was just published a couple of years back in the Journal of Perinatology. It's extremely well written, and I highly recommend it. A lot of the stuff that I will be talking about today I've stolen from Marty just because he did such a nice job. Another article out of Australia and Colin Morley's group is a very nice article on a practical guide to volume guarantee ventilation, which we're going to talk about today, volume guarantee and volume targeted ventilation, and how to use it. And we will be going very shortly to volume guarantee ventilation. So keep your heads up, because our current ventilators have now been fitted with a volume guarantee mode that we will soon be learning how to use. And this is really the way we need to go. The meta-analysis in the Cochrane database that just came out last year looking at volume-targeted, volume guarantee ventilation versus pressure-limited ventilation without volume-targeted, volume guarantee, as we will discuss, showed a definite improvement with decreasing chronic lung disease. And it was a fair number of studies, 14 trials, that were included in this Cochrane meta-analysis. And I think you'll understand the physiology of why that probably is related to better outcomes as we start going over some of the precepts. So do look at these if you have further questions or further interest. As well, I believe we're going to, this is being videotaped, so if you want to review the talk, or people that haven't been able to come today can look at it at a future date. Where's this going to be put so that people can find it? Do you have any idea? We'll let you know where it's going to be put.
I think we discussed in joint practice, all the videos going to come to the medicine and nursing and respiratory. We have a medicine drive, we have a nursing drive, and then we have a
okay. That's great. Okay. So, as you all know, respiratory failure is the inability to maintain pH, PCO2, and PO2 at acceptable levels. What acceptable levels are, of course, is a whole nother talk in itself. And we all know that things are changing rapidly in terms of where we want to keep our PCO2s and our PO2s and our saturation. So it's important that we all keep up on the literature about this so that we kind of have an idea of where we want to keep these things. And this is not something we're going to talk about today, all right? The goal of any mechanical ventilation is to get the patient off of mechanical ventilation. That is our primary goal, because mechanical ventilation contributes to a lot of badness. This includes, as we've talked about in some of our recent lectures, airway trauma, infection, decreased mucus clearance, overventilation, which is a huge issue that we will talk about more, contribution to air leak, and also contribution to BPD. And as we saw in the Cochrane review talk, was it yesterday, the day before, a meta-analysis of the current studies on use of non-invasive ventilation versus invasive ventilation shows a small but significant effect in reduction of BPD when non-invasive ventilation is used as opposed to invasive ventilation. So whenever we have a baby that's intubated, we should constantly be thinking, what can I do to wean this child? What can I do to get this patient off of mechanical ventilation? So I have a series of 3 or 4 really important slides. So if you fall asleep during the talk, I'll wake you up for the important slides. So this is the first most important slide, and that is something we really need to remember, that the lung is a dynamic, changing organ, especially during any acute pulmonary process. So that's why we have to spend a lot of time at the bedside, and we can't just do something and walk away or say, oh, yeah, maybe I'll make this change after a few hours or whatever, unless the baby is very, very stable. So especially during acute processes, and especially right after birth, and especially during any acute illness, the lung is going to be changing, and we have to remember that and try and stay on top of it. The most common problem really that I see is not staying on top of changing pulmonary mechanics, of not being Johnny on the spot with, okay, we need to know that we may need to make some changes fairly rapidly, fairly quickly, in order to stay on top of things and not contribute to further lung damage. All right, second most important slide. We're going to talk about oxygenation and ventilation throughout these series of 3 talks, because obviously those are the 2 most important things that we're trying to do. With oxygenation, with any form of mechanical ventilation, the single most important determinant of appropriate oxygenation is optimal mean airway pressure. The single most important determinant of appropriate oxygenation is optimal mean airway pressure. So the 2 key words there are appropriate oxygenation, that is, we're keeping your oxygenation where you want it to be, and optimal. Because we can oxygenate somebody at a very bad mean airway pressure, but that is not optimal, and that leads to lung damage. Nobody gets out of Stony Brook neonatal fellowship or residency without learning about my St. Louis arch slide. And as I talk around the country and even internationally, I always show the slide and I ask people where it is. And you'd be surprised at some of the answers I get. They'd say, Egypt? So St. Louis, which is not far from where I grew up in the Midwest, put this arch there. I'm not sure why, and I finally decided that they put it there to teach people exactly about lung mechanics. That's got to be why the St. Louis arch is there. And it's a nice picture of thinking about optimal mean airway pressure. If you think about pressure going from low to high along that happens to be the Mississippi River, not the Nile, and if you think about benefit as going up towards the sky, where you want to be is you want your optimal mean airway pressure at the top of the St. Louis arch, okay? Which is a very cool place to be. I've been there, and you look over the top and you see absolutely nothing below. It's sort of, you get a lot of vertigo. But you want to be with your mean airway pressure at the top of the St. Louis arch, because why? If you're over at the left side, what happens? The lung is atelectatic, isn't it? And atelectasis, we now know, is very dangerous for the lung. Because as you're trying to ventilate the atelectatic lung, all kinds of bad things happen. There are shear stretch forces, there's release of cytokines, there's damage to the lung just because you're trying to ventilate a lung that is atelectatic. On the other hand, if you're overdistended, we know that that's very bad for the baby too. We damage the alveoli, we stretch the alveoli, we rip the alveoli, we cause air leak potentially, we impede the venous return. So the cardiac output goes down, and so the blood from the brain also is having trouble getting down to the body, and that can lead to intraventricular hemorrhage. So both atelectasis and overdistension are bad things.
I need a change LVR number 8 for 33 refill, LVR number 8 for 33 refill.
She left.
Okay. A much more boring way, but the common way that you'll often see this represented is in this fashion. And again, just to review, with atelectasis and airway collapse, we have atelectic trauma, and with volume trauma and overdistension, we have poor right heart filling and impedance of venous return, possible air leak, and intraventricular hemorrhage in our population. I don't know, I certainly hope this works. It worked yesterday, so let's try it. A better way to show you the importance of appropriate mean airway pressure than this. This is a rat lung. It worked yesterday now, please. Don't tell me it's not going to work today. Oh man. I put it right on
No,
this.
the audiovisual doesn't work.
Oh, on this computer.
Yeah.
But it worked. I brought it in here yesterday
You
and
did?
it worked. Yeah. And I really don't know why it's not working. This is really disappointing me. Oh my God. Because it's a beautiful, beautiful
Yeah,
demonstration.
the play should be, the play button should be.
Right
No,
here?
no. Where you here?
Yeah, further up, little bit up,
No, no.
further up.
Further up.
Where that hazy shadow is.
Yeah, I
right.
think it should be some. Yeah.
Right next to where you were, isn't it? Go where you were at the front. Okay, next. Right? Right.
Right.
Go
No,
right, no,
right.
go right,
Don't click.
to the right.
No, click.
Come
Right.
do it here, Jariar. Show me how to do it.
I can see somewhere.
It worked yesterday.
Little shadow.
And it's just so dramatic.
Yeah.
You really would like
There
it.
you go.
Somewhere.
Down. Just go down, it's there.
Down.
Oh, there you go.
There.
No, not here.
Yeah, that's
That's
the
going to change the slide.
No, it's down. It's not on the picture.
Go back right up one.
Yeah.
Maybe if you make it smaller there.
And you have that bar that's not showing.
Yeah, make it a little smaller. And make it smaller the other way. No, not that way. The other way.
Go from the corner. Don't go from the
corner,
side.
not
Go
from the
from the
side.
corner. Hang on.
That's not going to work. Well, all right. Well, I don't want to waste too much time, but it's really, I don't know why the heck it didn't work. It doesn't work now, and it worked yesterday on this very same computer, but that's the way it is. I'm
Is
very,
it a
very
right
sorry.
click? No.
Right click. Try to get this, delete that out of there.
Options. Remove the options. No? Remove the options.
Well, shoot, it's always happening to me. What it shows is how important optimal mean airway pressure is, because this is a collapsed rat lung, and as appropriate PEEP is applied, you can see the lung expand beautifully, and how less tidal volume is needed to ventilate the lung when it's at optimal mean airway pressure. If we have time at the end, I'll try to get it to work. The only other thing I can do is go to, I've got it on the stick here. Just try this really, really quickly and see if it'll work. No, it won't. All right, well, for another time. So mean airway pressure during conventional ventilation is a calculation of all the pressures that you apply. Remember, mean is a mean. It's an average of all of the pressures that you apply to the lung. And it's important to understand that because during conventional ventilation and during jet ventilation as well, we're adding a lot of things together to create the mean airway pressure. And it's important that you understand what's going on here. This is time, all right, along the x-axis here, and our pressure here. And these are the breaths that we're giving, all right? This is our PEEP, okay? Our PEEP is the pressure that we've applied continuously, all right? Our PIP is going to be the pressure that we apply for the different breaths. The difference between the PEEP and the PIP is the pressure needed to create the what? The tidal volume, right? The difference between the PEEP and the PIP is the pressure needed to create the tidal volume, all right? We have a certain inspiratory time during which the peak inspiratory pressure is applied. We have a certain expiratory time during which the baby exhales down to peak. The mean airway pressure is the mean, all right? The mean of all of these pressures, all right? And it can be easily calculated by a formula that simply gives your peak inspiratory pressure and the time it's applied, all right? How long are you applying the peak inspiratory pressure? Divided by the total cycle time, all right? Because rate is going to have something to do with with the addition of all the pressures together, plus the PEEP and the time it's applied, divided by the total cycle time. It's very easy to calculate, even in your head, as you're bagging a baby and you're thinking, oh, what mean airway pressure do I want to start at? All right? If you have a PIP, for instance, of 20 and a PEEP of 5, if you have a rate of 60 and an I time of 0.3, it's very easy to say, okay, my PIP's 20, I'm giving it for 0.3 seconds, all right? My rate's 60, so that'll cancel out. That's only 1 second. You don't have to worry about that. And we're going to add the PEEP and the time it's applied. Now, an easy way to do this is to just call your I time 0.5 if you're bagging, because that will give you an approximation of what your mean airway pressure is, all right? And then you can just add that up, all right? In this particular case, it's 20 times 0.3, which is 6, plus 5 times 0.7, which is 3.5, which is about 9.5. So if I were bagging a baby on these pressures and I wanted to, say, start oscillation, I could say, all right, we'll start it at 10 or 12, and we'll go over those numbers and why we picked those in the next talk. But it's very important to know how that number is calculated, and that this is the important thing about oxygenation. The most important component of optimal mean airway pressure is using optimal PEEP. Why? Because it's the PEEP that keeps the lung open. And keeping the lung open at the optimal mean airway pressure is the most important component of oxygenation. If there's anything else today about oxygenation that you need to know, and it will apply also as we go into high frequency, is optimal mean airway pressure, optimal PEEP. The PEEP that's needed depends on the lung disease. If you have a baby with no lung disease, the PEEP that you need is going to be much less than if you have a baby with a lot of atelectasis who needs a higher PEEP. We have to be very careful about not being, as we all say, PEEPophobic, which means afraid of using the PEEP that we need to open the lung. The PEEP that we need depends on the disease that the lung has. So again, I show this to remind you that it's the PEEP that's really keeping the lung open. If we try and change our mean airway pressure predominantly by changing, for instance, our peak inspiratory pressure, what's happening there? Well, are we changing the mean? Yeah, we are. We're also increasing our tidal volume, aren't we? And we're going to talk a lot about optimal tidal volume when we come shortly to ventilation, because optimal tidal volume is critical to prevent lung damage. So, how do we do this, though? I mean, we don't have a baby who all of a sudden gets a green dot on his head and a little thing that says, congratulations, your baby is now at mean optimal mean airway pressure. Finding optimal mean airway pressure is hard. How to attain optimal mean airway pressure includes optimizing PEEP predominantly. How do you do that? You do that by attaining the lowest possible FiO2. Because think about it, if your mean airway pressure is at an optimal level, your FiO2 will be at the lowest level that you can get it to. All right? Because if you get atelectatic, your FiO2 is going to go up. If you get over distended, your FiO2 is going to go up. So optimal mean airway pressure, you're at the lowest possible FiO2. So if you have a baby with a high FiO2, the first question you should ask yourself is, have I optimized my mean airway pressure? A chest x-ray can be helpful. We want to look for the presence of atelectasis. We want to look for the evidence of lack of hyperinflation, and that includes predominantly flat diaphragms and a small heart. All right? Rib count is the least important part of that, because it's very hard to do accurately, and the baby may have other things going on that contribute to a rib count that's not particularly useful. So the most important things are looking at the lung fields for atelectasis, looking for evidence of hyperinflation, flat diaphragms, a small heart, and your FiO2. And sometimes you have to play around with it. Sometimes you have to go, you say, oh, well, I've got a little bit of atelectasis here, I'm not really sure. Let me try going up on my mean airway pressure. And if that's the right thing to do, what's going to happen to your FiO2? It's going to go down. All right? And when I sit at the bedside and I'm playing around with the ventilator, that's a lot of times what I'm doing. So I'm trying to optimize the mean airway pressure by going up or going down and seeing what happens to the oxygenation. All right? Because when you're optimally at optimal mean airway pressure, your FiO2 will be the lowest the lowest possible. Okay? A really critical point, and we're going to come back to it again and again as we talk about high-frequency ventilation. But it's also critical with conventional ventilation. And optimal peak is the single most important way of doing that. We're going to move now to ventilation. We're going to talk about control of CO2. During conventional ventilation, ventilation is attained by movement of gas in and out and diffusion of gas at the alveolar capillary interface. So you go, that's the bulk movement of gas in and out. And when the gas gets down there, there's diffusion of gas across the alveolar capillary membrane. Now this changes during high frequency. We're going to talk about other ways that ventilation occurs. But this is predominantly what happens during conventional ventilation. And we all know that tidal volume is equal to the dead space ventilation and the alveolar ventilation during conventional ventilation. Again, this is going to change a little bit during high frequency. So, third most important slide, everybody wake up. Avoid volume trauma. Excessive tidal volume, not pressure, is the predominant cause of ventilator-induced lung injury. That has been shown ad nauseum time and time again now, not only in the neonate, but in the adult and in the pediatric population. Tidal volumes of 4 to 6 mLs per kilo appear to be the safe range of tidal volumes for our patient population. We can talk about pediatrics and adults later on if you want to, but 6 per kilo is also considered to be optimal tidal volume in adult and pediatric population. But we're going to talk about our population right now, and 4 to 6 mLs per kilo with an average of 5 is in general where we want to be for our babies. And if we're in that range, then we are going to be minimizing the lung damage. There are many studies, the most classic of which were the rat studies and some piglet studies where the lungs were encased in concrete. And then there was a separate group where the lungs were not encased in concrete, and a lot of pressure was delivered to the lung of both groups. All right, and in the animals whose lungs were encased in concrete, you could put as much pressure as you wanted into that lung, and the lung was not damaged. All right, in the rats and the piglets, where the pressure was put in and the tidal volumes were then huge to deliver that pressure, the lungs were ripped apart and with appearances that were very similar to BPD. Those are some of the studies. The ARTSNet trial in adults showed increased mortality with high tidal volume, and on and on and on. This is an extremely critical thing. And it's not only critical in terms of the general tidal volume that we use, but it's also critical in terms of time. This is just one of many studies. Ventilation for 15 minutes with a tidal volume of 15 mLs per kilo initiates an injurious process in the preterm lung and a hepatic acute phase response. Subsequent ventilatory support causes further increase in some lung indicators, and that's just one of many. And in fact, Alan Jobe has some work that indicates, and he's done a lot of work in neonatal pulmonary, that as few as 6 breaths of tidal volumes of 10 to 15 per kilo causes a BPD-like picture in the preterm land model, which has been validated as its extremely close model to the preterm infant. In addition to this, we're going to now start talking about volume-targeted ventilation. This is one of the articles that I put on your sheet here. Volume-targeted ventilation means a ventilation that is changing in response to the tidal volume that you want. All right, and we're going to go over this a little bit more. But the conclusions in this Cochrane review and this meta-analysis of 14 trials of volume-targeted ventilation, predominantly done with the volume guarantee on the Draeger, but also with some of the other ventilators in Europe and a couple of ventilators over here that can target the tidal volume. The conclusion was that infants ventilated with volume-targeted ventilation modes had reduced death and chronic lung disease compared with infants ventilated using pressure-limited ventilation without a volume-targeted mode. Further studies are needed to identify whether volume-targeted modes improve neurodevelopmental outcome and compare and redefine strategies. However, death and chronic lung disease were decreased with these modes. Now, Inappropriate tidal volumes, therefore, require urgent correction. This is because of the data from the animal studies showing that even a few breaths with inappropriate tidal volumes or a period of even a couple of minutes with inappropriate tidal volumes can cause BPD-like picture. It is not something that we can say, oh, gee, call the therapist and after he comes back from lunch he can reduce the pressure on the ventilator. Inappropriate tidal volumes require urgent correction. However, the caveat to that is we have to be sure that the tidal volumes we're measuring are as accurate as we can get them to be. All right? When you're assessing your tidal volumes, if the infant's screaming and moving all over the place, it's not going to be accurate. So you have to assess the tidal volume during a period of quiet breathing. You have to assess the leak. Very, very important. If the baby has a very large leak, your tidal volume is not going to be accurate. All right? So you have to make sure your leak is minimized. And leak is very position dependent in our babies. We can reposition them, we can change their head position, and we can try and make sure that the leak is minimized. We also have to be sure that the flow sensor is working correctly. I came in the other day and there was something like 35 cc's per kilo tidal volume. Well, that was not even, I don't think, possible. We also have to be sure the weight is put in correctly. All right, and I forgot to put that on the slide, but that's absolutely critical. Sometimes we forget, sometimes, therapists may forget or whatever, to put the correct weight in, because if the correct weight's not in, you're going to get an inappropriate response. So even though this is absolutely true and our tidal volumes need urgent correction, please step back and assess the baby and make sure the infant's quiet, the leak is minimized, the flow sensor is working correctly without secretions and it's not reading something completely insane, and that the weight has been put in properly. If all that is true and your tidal volume is out of range, this is something that needs to be done right away. It's not something that you wait for an hour or so in order to change, because it can be extremely detrimental to the baby. All right? So we've really gone over two really, really critical things that you just have to remember whenever you're ventilating a baby, and that is optimal mean airway pressure, and for conventional ventilation, appropriate use of tidal volume. And as I think we're going to say at the end, but I'm going to say it right now, again, if you've got an appropriate tidal volume and you have an inappropriate mean airway pressure, you will still damage the lung. All right? So let me say that again. If you have an appropriate tidal volume and an inappropriate mean airway pressure, you will still damage the lung, because your lung will be overinflated or atelectatic, and that appropriate tidal volume is not going to prevent lung damage. Lung damage occurs from inappropriate mean airway pressures and from inappropriate tidal volumes. Both work together, all right, no matter what kind of ventilation you're using. Now, it's important during conventional ventilation to understand your ventilator. All kinds of different terminologies are used depending on the ventilator, but you really can take it down to fairly simple ways of classifying what's going on. And that's important when we get to volume guarantee ventilation, because it's very confusing. All right? So I want you to understand what's kind of happening. The modes of ventilation, there are three things you have to think about. What's initiating the breath? Is it the ventilator or is it the patient? All right? Intermittent mandatory ventilation. What initiates the breath? It's the ventilator. The ventilator, because there's no synchrony. All right, we don't use IMV anymore unless the baby's paralyzed or unless he's neurologically damaged. None of the ventilators have an IMV mode per se. You have to set the synchronized mode, but you can set a rate that the ventilator will say, okay, I've got to breathe this many times. The other modes, SIMV, synchronized intermittent mandatory ventilation, that's a synchronized mode. All right, the breath is initiated by the baby, but if the baby doesn't breathe, whatever rate you set, the ventilator will say, oh, okay, I've got to do that. All right, and then the baby can breathe in between. In assist control, the breath is initiated by the baby, all right? Unless, of course, the baby's not breathing, and then whatever rate you set, the ventilator will say, oh, okay, I've got to breathe that many breaths, all right? What controls the flow of gas? The pressure or the delivered tidal volume? In most people use time cycle pressure limited ventilation, which means it's pressure mode. And there are some reasons for that I'll briefly describe. In the newborn, we usually don't use volume control. It's a very difficult mode. Volume control means the ventilator is delivering a volume, all right? And it's not delivering a pressure, all right? It's delivering a volume. And the ventilator has to do a lot more things when it does that, because you have to take into account the compliance of the tubing and the compression of the gas and the humidification and so forth. So still we're using predominantly pressure modes, all right? The gas flow starts, you tell it, okay, stop at a certain pressure, and then the gas flow stops or goes down, all right? And what ends the breath, all right? Is it time or is it flow? During our time cycle pressure limited, it's time, because we tell it an inspiratory time. We say, okay, I want you to give this breath for 0.35 seconds. And it says, all right, I'll start my flow, and then at the end of 0.35 seconds, I'll shut off. It's important to know that pressure support ventilation is flow cycle, all right? That depending on the ventilator, a certain percentage of flow, the breath will then end. It's not time cycle, all right? So that's one of the differences between pressure support and assist control ventilation. It's just important to know those things. Volume control is also flow cycle. We're not going to talk a lot about that because we're not using volume control at this time.
So the termination sensitivity that we use, does it require a termination sensitivity at 5% or 10% to end the breath? Or
The pressure support will terminate automatically. I think the Avia does it at 25%.
Okay.
I'm pretty sure that that's what it is, but it differs ventilator to ventilator. Okay, now with the assist control breath, you can override your inspiratory time by turning on your termination sensitivity, and we all should do that, all right?
So that doesn't happen, like...
And they're actually automatically doing that now. I've seen on all of our ventilators, it's set usually at 5%, and we can go over that at some other time, because we don't really have time to go over that right now, but it's important to know that's the difference between assist control and pressure support. And everybody says, oh, it's all the same. Well, it's not quite. It's not quite. It depends on when you flow cycle that breath off, all right? So for practical purposes, everybody just needs to understand that when you're on assist control, you need to make sure that that breath is allowed to terminate sooner, because the baby may be breathing very fast, and if you've set an inspiratory time that's too long, then that can be very stressful for the baby, because he's trying to breathe out while the ventilator's trying to hold the breath, all right? Okay, so I want to talk about volume control, because we are going to be going to volume control.
You get the talk if you have an addition.
Okay. So, excuse me, we're going to be going to volume targeted. Volume control, in other words, where the ventilator is actually told to give a volume rather than a pressure, is very difficult to do in newborns, because as what I said, the volume has to be injected into a circuit which varies with gas compression, humidification, circuit compliance, leak, and blah, 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 blah. It's done successfully in pediatrics and adults. In fact, that's the predominant way that kids and adults are ventilated. It's more difficult because of the smaller volumes in the newborn. It's not impossible. Some people in the field do use it occasionally, and some people really like that mode. But in general, it's more difficult to do, more difficult to control, and it requires a lot of recalibration, sometimes as much as hourly, to make sure that you're doing the right thing and giving the right volume. So the thing that I want you to understand is that with time cycle pressure limited, which is what we do, in other words, we set a pressure, right, and we set an inspiratory time. The tidal volume is not set by us. However, it can be controlled by the ventilator when volume targeted or volume guaranteed modes are used. So volume targeted and volume guaranteed modes are pressure modes. They're not volume modes, and that's the big misunderstanding that a lot of people have. But the ventilator can control the volume using a microprocessor. So volume targeted or volume guaranteed, which we are going to be doing, is not a volume mode. It is a pressure mode that allows control of the tidal volume by adjusting the pressure. Really, really important, all right? It will control your tidal volume by adjusting the pressure. So it's a pressure mode. There's a microprocessor in the computer that measures the tidal volume of the previous breath and adjust the peak inspiratory pressure to achieve the set tidal volume. I just want to make sure everybody understands that. You understand that, Alexa? Okay. So it's measuring the breath before. It says, that tidal volume is not quite where they want it to be, so I'm going to take my pressure up a little bit. Or it says, the tidal volume is too much, so I'm going to take my pressure down a little bit. So it's a very active adjustment so that that tidal volume, which is so critical, is adjusted.
Is it done on breath to breath?
It's breath to breath. And it depends on the ventilator, whether it's the previous breath or the previous series of breaths. And I don't know how the AVIA does it, because I haven't been in service on it yet. But either one or several previous breaths are averaged. It's a moving average. And the ventilator then adjusts the pressure to keep your tidal volume where you want it to be. So I think you can see how valuable that could be. If giving too much tidal volume is so dangerous, and it is, then if we can adjust our ventilator kind of constantly so that our tidal volume stays where we want it to be, the chances of lung damage are less. And in fact, the meta-analysis that I went over with you briefly shows that. It shows that when you use these modes, incidence of bronchopulmonary dysplasia is decreased, which is obviously why all the ventilators are now going to this. This was first run up the flagpole by Draeger with volume guarantee, and now everyone else is realizing, based on the studies that have been done, that this is really where we need to be going. And that just setting a tidal volume and coming back every few minutes to make sure you're in the right range is not nearly as effective or possible, because we can't even do that, as volume control, volume guarantee modes. So both too high and too low tidal volumes are potentially dangerous. If you have a high tidal volume, you can have lung damage, air leaks, and hypocarbia. Low tidal volumes lead to increased oxygen need, damage from hyperoxia, hypercarbia, which we also know is dangerous, and increased work of breathing in the baby. So we have to keep our tidal volumes constantly adjusted. And as I stated earlier, optimal tidal volume will not work if an open lung strategy is not employed. We really have to be sure that both things are occurring. Our mean airway pressure is optimized for our oxygenation, and our tidal volumes are optimized for our ventilation. If we don't do that, then one of the problems is surfactant inactivation. Surfactant is inactivated by atelectasis. Surfactant is inactivated by overdistension. Okay? And if surfactant is inactivated, then obviously we have a whole other problem. Surfactant is also inactivated by meconium and other irritants to the lung. Inflammatory mediators are increased in the presence of atelectasis and overdistension. The shear forces, you can think of blowing up a balloon and how hard it is to blow up the balloon at the first part of that. Those shear forces are very damaging to the lung, and overdistension of normal areas that leads to damage of those areas. So, most important slide, everybody that's fallen asleep, wake up. Our goal should be tight control of both the mean airway pressure for optimal oxygenation and the tidal volume for safe and effective ventilation. And I took a couple of quotes from Marty. Mounting evidence shows that optimization of lung volume is key to lung protection, regardless of what ventilation mode is used. And I think this just can't be said better. There are certain cases where we need oscillation. There are certain cases where we need jet ventilation. But if we pay attention to this, if we can optimize our mean airway pressure and our tidal volume, and we can do that with conventional ventilation, then there's absolutely no reason why we need to go to another form of ventilation. It's when we can't do that that we do need to go to another form of ventilation. And again, if you don't optimize your lung volume, then your tidal volume is not going to be helpful for you. All right, so in the remaining few minutes, I just want to talk a little bit about some of the other things that have come up from time to time. Pressure support is a patient breath and only a patient breath. All right, it is not initiated by the ventilator, it is only initiated by the patient. If the patient doesn't breathe, there is no pressure support breath. All right, it supports the baby's own breaths, it's not a ventilator breath. It gives some positive pressure to overcome the resistance of the endotracheal tube. And it terminates the breath at some percent of the peak flow, and that depends on the ventilator. All right, and like I say, I think maybe it's 25%. But it is not a time cycle termination, it's a flow cycle termination. Okay? That allows the baby to adjust his own inspiratory time. All right? It is a patient breath. Everyone needs to be familiar with the real-time waveforms that are on our ventilator and what those are telling us. And you need to take some time to look at what's going on with the tidal volume, all right, the flow, and the pressure during time cycle pressure breaths. The pressure is going to slowly rise, all right, look at your flow is going up, then the flow on inspiration goes down, so your pressure is going to stabilize. And then as we cycle into expiration, then your pressure is going to fall back to zero. Your tidal volume rises to a certain point when your pressure is at a maximum and your flow, all right, your inspiratory flow, all right, has terminated, okay? And we will have another talk on how to interpret these in terms of the graphics, because it can give you a whole lot of information just by looking at the graphics. It can tell you if you have a big leak. It can tell you if you have inadvertent peak, all right? It can give you a lot of information that sometimes we don't pay enough attention to. So looking at graphics can be very, very important. Leak is something we have to pay attention to. Because we use uncuffed endotracheal tubes, there will by definition be a leak between the tube and the trachea. Pulmonary mechanics measured with uncuffed endotracheal tubes are inaccurate. That's one of the reasons why we can't do pulmonary mechanics and use them in the NICU environment. It's a research tool because of the inaccuracy of the leak. There are certain things you can do to minimize the leak. You can look at trends, provided that your leak is minimal, but you can't use them as absolutes. So that's an important thing to realize. Also remember that your leak is always greater on inspiration, because as the airways distend, then there's going to be more leak. All right, that's why we use expiratory tidal volume, all right, because that's minimal leak. All right. So if you have a consistently large leak and you've adjusted the head position, remember it's like breathing through a little straw. You've got a big leak, you can't get it to go away, then you need a larger endotracheal tube. The trachea of the baby expands when the tube's been in for a long time. All right, so it doesn't really matter the size of the baby, it matters the size of the trachea. All right, so if you have a large leak, and in general we're talking about consistent leaks greater than 30%, then consider a larger endotracheal tube, because you will not get accurate tidal volumes, and that's something you really have to assess, as we've talked about, and the baby will be, his work of breathing will be increased. Some ventilators do some leak compensation, which can be sort of effective, but the point is not to try and compensate for the leak, but to get the proper size tube in the baby so that he can be most effectively ventilated. Triggering is something that you have to understand a little bit about. That somehow the ventilator has to know when the baby's breathing, so it can trigger a breath. Some way of flow triggering is the most common thing that we see. Now the flow sensor, all of the flow sensors that we use add a little bit of dead space. And this is something just to put in the back of your head. If you have a very small infant that you're trying to use appropriate tidal volumes on, you may want to ventilate that baby with a little bit on the higher side of your tidal volume range. In other words, instead of the 5 cc's per kilo, you may want to use 6 cc's per kilo. And the reason for that is the dead space, because that will affect the delivered tidal volume in the very small baby. It's only about 1 ml in most sensors, but it can affect your tidal volume. So if you have a little tiny baby, think about using a little closer to 6 cc's per kilo, just because of the dead space of the flow sensor. And also remember that if you have large leaks, the machine may misinterpret and may think it's a breath if it's getting a leak through the endotracheal tube, and cause the machine to auto-trigger. So all of a sudden you're getting 100 breaths per minute on the ventilator, and you're saying, well, what on earth is going on? Think about a leak. and whether or not you need to adjust for that or change the size of the endotracheal tube. A couple of recommendations with SINV. Pretty much nobody is using SINV anymore without pressure support. The problem with that is that you've got the baby's trying to breathe in between the breasts. He's got a high resistance of the endotracheal tube. He's rebreathing dead space, and higher tidal volumes are needed. And you can see a nice graphic representation of that in Marty Kessler's article, which is the first reference there. So if you're going to use SIMV, that's why we do here, and that's why we do it. Because that baby needs to be supported on the breast that he's breathing in between the SIMV breaths. Assist control, remember that it's perfectly possible to leave a baby on assist control and wean him from assist control to CPAP. No problem there. Remember to set the rate on your assist control beneath the baby's spontaneous rate. Otherwise, he's just going to be riding the ventilator. So you have to wean him by weaning his peak inspiratory pressure, wean it down, keep the rate below the baby's spontaneous rate. When your peak inspiratory pressure is low and simply just overcoming the resistance of the endotracheal tube, when your X-ray is fairly clear, when your FiO2 is low, when the baby's breathing, he can be extubated. And that's a perfectly acceptable way, and many nurseries do that, to wean the baby. The other way, of course, is to use SIMV and then wean your rate off, either to pressure support or something fairly low, and then extubate the baby. So, most important slide again, and I think we're just about on time here. For babies who do require mechanical ventilation, the combination of volume-targeted ventilation combined with the open lung strategy appears to offer the best chance of reducing the risk of chronic lung disease. So it's almost 9. I'm going to stop there, and I'm going to just see if anybody has any questions.
Going to the CMEs?
What's the open lung strategy?
The open lung strategy is optimal mean airway pressure.
Oh, okay.
The lung is open, but it's not over distended, and it's not anaerobic cavity.
Thank you. Do you have a CME?
Is volume guaranteed? You said it's still pressure.
It's a pressure mode.
Pressure mode.
It's a pressure
So
mode.
you're still setting.
Yes. And
But then it adjusts
what
around.
most people do is set the PIP fairly high, because otherwise your machine may alarm a lot. Remember that set PIP is never going to be attained unless your volume is not delivered. Because what you're going to set, you're going to say, I want you to deliver this volume. And the ventilator will then adjust the PIP to get to that point. If you set your PIP too low for the ventilator to alarm, then every time the baby moves or takes a sigh, your alarm's going to go off. But you don't really have to worry about that PIP being dangerous, because it's never going to get there, you know, unless the baby requires it or unless he's screaming or something like that. All right. So you set a PIP upper limit. The most important thing is setting your tidal volume, and then the machine will adjust the PIP by itself. And it will also wean the baby. And this is, you know, think about it. If it's adjusting that PIP, then as the baby's compliance improves and as the baby gets better, the PIP needed is going to go down. So it's an auto wean mode. The ventilator will take that PIP right down, because it's only going to deliver what PIP is needed to deliver the tidal volume that you've set, which is the beauty of it. So it is a pressure mode. It's an auto wean, auto regulated mode. Do you guys know when we're going to be up and running with in-servicing? In the meantime, we just need to be very careful and do the best we can with setting our tidal volumes.
Are there some diseases that have higher volume requirements?
Yes.
You know?
There are, and for us, it's predominantly our BPDers. Yeah, and that's a whole different game. However, we try very, very hard not to go above 7 or 8 cc's per kilo, even in those babies. Now, you take somebody like Tansy, all bets are off. I mean, that's a terminal lung. But
BPD with pulmonary hypertension.
So in those cases, you're targeting SATs, because you don't really know what their volume needs to be.
well, you try to keep your volume within a reasonable range as much as possible. Consider other forms of ventilation if you're using very high tidal volumes, because you will continue to damage the lungs. If
The
you're using
data.
high tidal volumes.
Courtney, I just have a question about BPD volume data that's available. is being done on older BPD, nothing on new BPD.
Very
right?
little data.
Very little data on older like on new BPD. You need to understand the pathophysiology of older BPD versus new BPD. The fibrosis is a very nice article I can forward to everybody. The fibrotic changes are more with the older BPD, and with the new BPD you see alveolar septation, and you also see a pulmonary capillary dysplasia, like an arteriolar or venular dysplasia. So when we talk about the volume on those babies, there's no data, very slim data that I can
It's a
look at.
different situation, but nonetheless, you do want to try to keep your tidal volumes in range as much as you possibly can to minimize further lung damage. And of course, try to prevent it in the first place by keeping optimal open lung strategy and optimal tidal volume.
Everybody to see me?
Could you just go back to the previous most important slide? I think I was just getting understanding that.
Previous most important slide.
Oh wait, this one. I'll go to check both mean air pressure and tidal volume.
We'll come back to these things again and again and again and again. It's the crux of any form of ventilation, including CPAP.
Thank you, Courtney.
Thank you.
Thank you very much.
Thank you.
This is for next week.
Yep.
Are you on our team?
Wait, I just signed it because it's a sign away.
Oh, no. Didn't she?